Welcome back to Ellie Scrubs In. Today's case is one of the most commonly performed surgical procedures worldwide, the Cesarean section or C-section. This video will walk through the typical steps of the operation, the instruments used, common variations, and pearls and pitfalls to keep in mind. We'll focus on a standard low transverse cesarean section, which is the most commonly performed approach in the US. Let's scrub in. Step 1. Indications and preparation. Common indications for cesarean delivery include non-reassuring fetal heart tracing, failure to progress, prior cesarean delivery, placenta previa, or breech presentation. The patient is placed in the supine position with a left lateral tilt to avoid aortocaval compression. Regional anesthesia via a spinal block is most commonly used, but general anesthesia can be used in emergent cases. Fetal heart tones are confirmed. A urinary catheter is placed, and abdominal prep and sterile draping are performed. Step 2. Skin incision and entry. A Phalansteal incision, a low transverse skin incision just above the pubic symphysis, is made using a number 10 blade. Dissection proceeds through the subcutaneous tissue using the 10 blade in the midline until the fascia is visible, followed by blunt dissection of the lateral margins. Electrocautery is used to control bleeding. The fascia is opened sharply and extended laterally with curved Mayo scissors and Richardson retractors. The superior margin of the fascia is grasped using Coker clamps and bluntly separated from the rectus muscles. Rectus muscles are separated bluntly in the midline, and the peritoneum is opened to enter the abdominal cavity. Pearl. A sharp dissection of fascia, followed by blunt dissection of the rectus muscles, minimizes bleeding and preserves tissue planes. Step 3. Uterine exposure and incision. The uterus is exposed by placing a bladder blade retractor inferiorly and using Deaver or Richardson retractors laterally. The bladder flap is created by dissecting the peritoneum off the lower uterine segment, using blunt dissection or Metzenbaum scissors, then pushing the bladder inferiorly. A low transverse incision is made in the lower uterine segment using a scalpel, then extended bluntly with fingers or bandage scissors. Pitfall. Avoid extending too far laterally where the uterine arteries run. Uncontrolled extension risks hemorrhage or broad ligament injury. Pearl. If the lower uterine segment is poorly developed, e.g. preterm, a classical vertical incision may be required instead. Step 4. Delivery of the infant and placenta. The fetus is delivered manually, with gentle fundal pressure. In breech or transverse lie, special maneuvers may be required, such as the Pat-Wardhan technique or internal podalic version. The cord is clamped and cut, and the neonate is handed to the pediatric team. The placenta is delivered by gentle traction on the cord and manual sweep. The uterus is wiped clean and inspected for retained fragments. Pearl. Always inspect for a succenturiate lobe or retained fragments to reduce postpartum hemorrhage risk. Step 5. Uterine closure. The uterine incision is closed in 1 or 2 layers using absorbable suture, such as number 1 chromic or vicryl on a CT1 needle. Some surgeons use a running locking stitch, while others prefer interrupted or figure-of-8 sutures for additional hemostasis. Pitfall. Inadequate approximation of the uterine edges increases risk for uterine rupture in future pregnancies. Avoid excessive inversion that can narrow the endometrial cavity. Pearl. Palpate the cornua to ensure both angles are closed and that no bleeding points remain. Step 6. Abdominal wall closure. Hemostasis is confirmed. The bladder flap may be reapproximated with fine absorbable suture, and the peritoneum is often left open, but can be closed based on surgeon preference using absorbable suture. The fascia is closed with a running locking absorbable suture, typically number 1 PDS or vicryl. The subcutaneous layer may be reapproximated if thicker than 2 centimeters to reduce seroma risk. The skin is closed with staples or subcuticular suture using a 5-0 monocryl on a PS2 needle. Pearl. Subcuticular closure, followed by glue or steri-strips, may improve cosmetic outcome and patient comfort. Postoperative care and recovery. Patients are monitored for bleeding, infection, and uterine atony. Early ambulation is encouraged to prevent thromboembolism. Analgesia is typically managed with a combination of NSAIDs, acetaminophen, and opioids as needed. Discharge is usually within 2 to 4 days. Return precautions include fever, foul discharge, heavy bleeding, or wound dehiscence. Patients usually follow up in the office after 2 weeks for examination of the incision. Breastfeeding support and maternal-infant bonding are key parts of recovery. Final thoughts. Cesarean section is a fundamental procedure for any surgical learner in obstetrics. Although standardized, it requires attention to detail, anatomical knowledge, and coordinated teamwork. By understanding the variations and maintaining meticulous technique, outcomes can be optimized for both mother and child. Thanks for scrubbing in with Ellie Scrubs In. Be sure to like, subscribe, and check out our growing library of narrated surgical walkthroughs.